All right, looks like we've got everybody here and signed up for the meeting. Thank you so much for your time today. It's really great to have this many people on one of our webinars. KanTime is honored to jointly host this webinar on Deprescribing today with WISE Hospice Options. My name is Greg Lotz, and I'm the Director of Partner Management at KanTime. We've been integrated with WISE Hospice Options for some time now, and WISE Hospice Options gets rave reviews from our mutual customers. Also with me today from KanTime is Deanna Heath, our Director of Hospice and Hospice Customer Success, and Kristen Duell, our EVP. I'd like to share a little bit about KanTime, and then I'll introduce our skilled presenters from WISE Hospice Options. KanTime is an enterprise software solution that covers every aspect of the post-acute industry. If your organization provides a healthcare service delivered at home, KanTime can be configured to support that line of business. We know that the hospice line of business is the current focus for most of the attendees today. But as you grow and the opportunity arises, we will be there to help you embrace it. All right, well, let's get into the meat of the presentation today. We've got a lot to cover. First, I'd like to introduce our presenters from WISE Hospice Options. Deanna Rice is the Vice President of Clinical Services with WISE Hospice Options, with a decade of experience in pharmacy benefit management, hospice care, symptom management, and education. She received her doctorate in pharmacy from the Medical College in 2001. Prior to hospice, she managed a post-acute national home infusion business with additional experience in pediatric and neonatal acute care services. Deanna is passionate about providing quality care and collaboration for maximizing one's quality of life with end-of-life care. David Bougher is Senior VP of Regulatory Affairs for WISE Hospice Options. David graduated with an ADRN from WVNCC in 1983 and earned his BSN from West Liberty University in 1998. He was an ICU nurse for the first 14 years of his career. From 1996 through 2009, he held a variety of positions from primary nurse to Director of Clinical Services and Hospice. Since 2009, David has been with WISE Hospice Options, serving as an account manager, regulatory expert, editor of the newsletter, and participates in clinical education and development. So without further ado, let's go ahead and get this started. David, you have the control.
Great, thanks so much for that introduction. Greatly appreciated. WISE Hospice Options has been a hospice-only PBM for over 18 years. We have a number of partnerships. One of our greatest ones is with KanTime. We have an interactive interface that does both the demographic information and medication information, which makes for a very smooth transition in ordering medications, admitting patients, etc. We're benchmarked by MVI out of North Carolina as the lowest cost PBM, not meaning we're the cheapest, but we do help you keep your cost reasonable. And we're also known for our innovative technology and enhanced hospice solutions. So as Greg said, today we're going to look at a topic that has gained a lot of traction recently. It's not new, it's been around for a long time, and certainly those of us who've been in hospice have done deprescribing probably from the very beginning of our careers. Deprescribing really takes a look at a more formalized approach. We're seeing a lot of research out there. We're seeing a lot of algorithms being written and around the places like cardiology and thoracic medicine as well. So when we take a look at this, we're seeing much more formalized process being devised. The problem right now is that there's a lack of research in the elderly, and especially in the frail elderly. And that's something that we're hoping to see more of as time goes by. You have to remember that at one time medications were good, but they may not be the best choice now. And that's not because the medication has changed. It's because the impact of aging on the pharmacokinetics and pharmacodynamics change. And this increases the risk for adverse events or more drug-to-drug interactions. And Deanna's going to talk about this as we go through more specifics. When we look at an organization called Deprescribing.org, which was a collaboration between a group in Canada and a group in New Zealand, who put together the research, who put together the algorithms, and a lot of patient education information. You can go to their website and they allow you to use anything they have as long as you give them credit for it and don't edit that information. But they look at deprescribing as a planned process of dose reduction or the stopping of medication that might be causing harm or is no longer of benefit. And when we look at medications in our setting, medications fall into three categories. They either manage a symptom well, they are no longer of a benefit, they do nothing, or the worst case scenario, they actually cause harm. And we have both a clinical and an ethical obligation to look at those drugs in those two categories and begin those discussions about discontinuing or at least decreasing those drugs. So deprescribing is also a good part of prescribing, backing off when doses are too high or stopping medicines that are no longer needed. Now, this sounds simple when you put it this way, but we all know it's a much more complex process. It requires a lot of discussion. The Journal of American College of Cardiology also has put out their own statement about deprescribing, and if you look at their website, they look specifically at the cardiac medications, which are a big part of many of our patient case mix, because we have, the big three non-cancer are the dementia patients, the cardiac, and the respiratory patients. So their description or their definition is deprescribing is an integral component of practices. It's to improve outcomes, reduce costs, and all of this, the real bottom line for all of this is enhanced quality of life. So why deprescribe? We didn't start these patients on these medicines. Why not just leave them alone? Well, part of it is that deprescribing is looking at the volume of medications and the variety of medications that patients on. A pure definition of polypharmacy is a patient who is on 5 or more medications a day. And I can actually hear your eyes roll because if you've got a patient with 5 medicines, you think that's a gift, because so many of our patients come to us with 10, 15, 20 medications when you combine the scheduled prescribed medications and the PRN medications that a patient could be on. And Deanna's going to bring up a case study that's going to take a look at that. So we know that polypharmacy correlates with increased drug-to-drug interactions, adverse effects, morbidity and mortality, pill burden, which is a huge issue, and cost as well. So we want to, when we're looking at this, we want to consider the patient's age, and not just their chronological age, but their overall age or level of frailty. You can have that 96-year-old who looks 60, and you can have that 40-year-old who appears to be in their 70s or 80s. So it's not just chronological age, it's level of frailty, what their disease trajectory is, and what their overall prognosis. Many of these medications, depending on dose and duration, require a fair amount of time to decrease either the dose or eliminate them completely. Many times you can't stop them abruptly. We want to make sure we assess the individual's values and goals of care. And that should be a given for most of us. We don't go in there and we determine what the goals are, they do. We want to know what their cognitive and physical function is, their multi-morbidity and medication burden. And all of these play into this. We want to balance the risks and benefits at the level of the individual. And discussion of deprescribing should be an integral component of hospice care. And this should start at the time of admission. Deanna and I, for our organization, take clinical call, and about 30% of our calls are from admission nurses who want to go through the patient's medication list. And there are very evident drugs in that list that could be deprescribed or discontinued altogether. But that's not necessarily the time to do it, but it is the time to begin to approach that subject going forward. And again, probably at the end of every slide, we could put, if we do this right, we improve a patient's quality of life. So what are the goals of deprescribing? It should be part of good clinical practice. We want to remove the removal of or dose reduction of medications in an organized manner. We want to plan how we're going to do this. And it isn't, we might see that there's 3 or 4 medications in a med profile that we want to deprescribe, but we've got to pick those first and foremost that are the most troublesome or have the highest risk. And we're going to want to do it again in that organized manner. We may not be able to discontinue a medication abruptly. It may require a titration down over days to weeks in some cases. The other goal would be to reduce the pill burden, lessen the risk of adverse drug events. You hear Deanna talk in a couple of cases that a patient may be put on a medication, they have side effects and they get put on 1 or 2 other drugs to ameliorate those side effects rather than change that drug. The oversight of the deprescribing process should be done by appropriate members of the healthcare team. We should be looking at improving 1 or more specific outcomes. And we want that as a part of our planning process. What do we expect to occur? And once again, enhance or improve quality of life. So at this point, I'm going to hand it over to my colleague, Deanna Rice, and she's going to take you through some more specifics.
Thank you very much, David. I appreciate it. So to get started with my portion, of this presentation, I'm going to provide what is a very simplistic algorithm, knowing that this is a stepwise approach as we look at deprescribing and as a patient is admitted to the hospice setting. So to get started, we'll look on one hand, we basically have a patient who is taking what we call medication A for a condition, medication A. And we're going to determine that potentially it's not providing any kind of palliative benefit. And we really need to consider deprescribing. This potentially, again, is going to be an abrupt discontinuation dependent on the dose and other parameters, or we're going to taper and discontinue the particular medication. Regardless, it will require ongoing monitoring. On the other hand, we've got condition B, which is determined a chronic condition in which the medication is necessary to continue, and we will certainly manage and continue to monitor this indication ongoing. It's important to recognize that there's certain indications that may be necessary to continue medications for as they're admitted to hospice, something like hypertension. They could be on a comprehensive hypertension regimen that is very necessary, but as they start declining, this medication regimen should be looked at, continued to be looked at, potentially tapered and be prescribed accordingly as they become normotensive and then potentially hypotensive. So looking again at the simplistic algorithm, we want to look at the dose, the frequency, and the route. We want to consider the formulation that they're on and the ability to give the drug, the ability to maintain the drug. We want to look at how long they've been on the particular medication. So duration of use is very important. If they've been on a chronic med and it's a rather high dose for an extended period of time, it's most likely going to require a dose taper, significant monitoring with a potential to deprescribe. On the flip side, if they are on a minimal dose and it's a medication that they've just recently started, we could consider an abrupt discontinuation. We want to understand why they're taking the medication or the indication associated, and is it necessary or palliative to continue the medication? Are they compliant? This is a big question. If there is a chronic condition in which they've been receiving medications for long term, have they been taking them? If they've not been taking these medications, it's probably not providing any clinical benefit. If they've been taking them intermittently and it should be a scheduled medication, it's probably not providing benefit. So this is certainly something that we need to consider as we continue medication management. Side effects and drug interactions. There are a lot of significant drug-drug interactions that we manage through with our hospice patients. As we add medications for palliation of symptoms, these drug interactions can become more significant. Side effects, as David mentioned, we can start a medication for a particular indication, and inevitably it's going to create a side effect. We can term this the prescribing cascade, in which the medication is started, a symptom or a side effect occurs from the particular medication, and then we start another medication or two to control those symptoms. An example would be a little old man who's struggling with his everyday, life as he's aging, and he asked his doctor for some help with, just some slight mood changes and, depression issues and that sort of thing. So he's prescribed Wellbutrin to take for his depression. He wasn't given specifics on how and when to take this, so he decides to take his Wellbutrin at nighttime before he goes to bed. A couple weeks in, he's recognizing that he's not able to sleep at night. So he goes and he peruses the OTC aisle to find something called Sleepies. He reads the package and it says that it's going to help him sleep, not understanding really what the other issues that are going to be incurred by starting this particular medication. But he's all excited and he takes his Sleepies home and he takes it before he goes to bed. And he does this nightly for a week or so, and then recognizes that he's got some real dry mouth, he's now constipated, and he just has an overall hangover-like effects, and he's not certain as to why. So he goes back into the drugstore and talks to the pharmacist behind the counter and just kind of backtracks through his story of starting the Wellbutrin and starting the Sleepies and the issues that he's now concerned about, the dry mouth, constipation, and fogginess. And they recognize that he's taking Sleepies, which is a form of Benadryl. He is older, so this is a significant risk for an individual, and certainly not the sleeper of choice in the elderly. They also recognize that he is taking his Wellbutrin at night as opposed to in the morning, which could have been causing or worsening his sleeping issues. So they get him back on track. They stop the sleepies. They start the Wellbutrin in the AM as opposed to the PM, and he goes on his way with minimal issues. The last little bullet point here is management, assuring that if we're discontinuing medications or continuing them, that we continue to manage those particular medications and the need for those particular medications. So I've got a little case study here, again, very simplistic, but we have this new hospice patient. She is an 83-year-old female. She's got late stages of frontotemporal dementia. She's got a PPS of 20 and a FAST score of 7E. Her comorbidities include hypertension, diabetes, arthritis, hypothyroidism, chronic constipation. She lives in a long-term care facility. Her current weight is 94 pounds. She's dependent for all ADLs. She's incontinent. She's got a poor appetite, and she's restless and agitated on occasion. Her blood pressure is 98/56. She's got 1+ pedal edema. Her lungs are clear, and she's got active bowel sounds. This is a list of her current medication regimen as she's admitted to hospice. If you can count the number of medications that she has profiled here, you'll come up that she has 13 scheduled medications and 6 medications that are used as needed, totaling 19 medications. As David referenced, polypharmacy is defined as 5 medications or more. So this particular little lady is definitely struggling with the polypharmacy, and pill burden certainly can, and I'm certain is, an issue. A few of these scheduled medications to point out that would be red flags if I were doing a med review on this particular patient. The first one would be Linzess, the Namzaric, the Nuedexta, and the Zyprexa. Again, keep in mind these couple that I'm highlighting as we go through, and we'll reevaluate as I finish up with my conversation here. So looking at the low-hanging fruit, or those medications that are easiest to discontinue, with our goals at hand still being number one, to improve quality of life, and also to decrease pill burden. We certainly want to evaluate and eliminate where we can. So looking first at the multivitamins and the supplements, we need to recognize that these provide no palliative benefit and should be discontinued. Statins and anti-lipemic agents, those classes of medications that we use for hyper cholesterol, or high cholesterol, I'm sorry. We need to recognize that post-discontinuation, 60 days post-DC, there's no increase in morbidity or mortality when these particular medications are stopped. Statins come with a significant side effect that we know as myalgias or significant muscle pain. Stopping statins at end of life can actually improve quality of life significantly in that regard. Bisphosphonates are used for osteoporosis. We should recognize that the literature supports that bone mineral density actually stabilizes after about 3 to 5 years of use. This class of medications is not easy to administer. It is required that the individual swallow the medication with a full 8 ounces of water, not take any other meds that are scheduled within with that administration, and they must stay upright for at least 30 minutes. H2 antagonists and proton pump inhibitors. H2 antagonists, examples would be something like Pepcid. Pepcid is indicated for 2 weeks of use for mild to moderate reflux, not extended use necessarily. With extended needs, we want to really consider proton pump inhibitor. However, it should be recognized that prolonged use of proton pump inhibitors is defined as greater than 8 weeks. I do find that this particular class of medication is prescribed, and years later, or rarely never, is it ever reevaluated. This group of medications is not without side effects. Prolonged proton pump inhibitors can affect the GI and cause C. difficile. It also can affect the lungs and increase the risk of pneumonias. It also has an effect on the bones and can increase the risk of fractures. Ophthalmics, all eye drops can be difficult for administration by the individual or even a caretaker. They are also known to have significant side effects, such as headaches and affecting vision. So these are a grouping of medications that a patient may actually appreciate being done with as they're entering the hospice benefit. I mentioned drug-drug interactions. There are many to speak of. The ones that I see most commonly occurring are these 3 that we have bullet pointed here: serotonin syndrome, QTC interval prolongation, and decreased seizure threshold. Know that these drug-drug interactions are a dose and cumulative risk, meaning the more drugs that we have on board that can cause these side effects, and the greater the dose, the greater the risk. So examples of those medications that can incur serotonin syndrome would be morphine, fentanyl, trazodone, and Buspar. Those, again, are highlights, certainly not an inclusive list. We want to recognize signs and symptoms of serotonin syndrome as we're managing an individual. Some would include sweating, tremors, and restlessness. QTC interval prolongation. Examples of medications that would increase this risk. Significant is methadone, and often used in the hospice arena. Also Zofran, antidepressants such as citalopram, the antipsychotics or the mood stabilizers that we use such as Seroquel. Know that signs and symptoms to manage or monitor through of QTC interval prolongation is dizziness, heart palpitations, fainting. We could also, or our individual could also be at risk of seizures. Those that are at an increased risk are elderly, those with a cardiac history, and the female gender. Decreased seizure threshold or an increased risk of seizures. The meds that can increase those risks include the majority of the analgesics, antidepressants as a whole, antipsychotics, or mood stabilizers. Not recommended in the frail and elderly. And just to provide some clarification on this particular slide, we say not recommended. Oftentimes these classes of medications are used in our frail and elderly, but we need to use them with great caution. So the antipsychotics, first and second generation. First generation, an example would be Haldol. Second generation, an example would be something like Seroquel. We do use them for behaviors in our elderly population, but we want to use them on a limited basis and recognize that they're not without risk. Again, antipsychotics are used for mood stabilization, but we want to look at the individual as a whole. Since antipsychotics or these mood stabilizers actually increase the risk of mortality in our older population with dementia, we want to trial discontinuations as we are starting these medications, continuing them, determining whether or not they're providing a benefit or not. Also considering that as their disease progression continues, that their moods or their behaviors can worsen, can change, and we may be getting no real benefits from these particular medications. Therefore, trials of discontinuation are necessary. We also have to recognize that symptoms may never be totally resolved with this particular patient population. And oftentimes the adverse effects associated with the drugs are a greater risk to the individual than continuing the medication. Benzodiazepines, tolerance does become an issue with this class of medications. When these are prescribed for insomnia, know that the benefits may last at most about 4 weeks, and that particular benefit wears off. The half-life of this class of medications can vary from medication to medication and certainly should be considered as we're utilizing this medication and looking at the side effects. Xanax, if our patient was taking a Xanax tablet for sleep, know that it's short acting. If and when we stop, or when we stop it, excuse me, know that the long-term effects will be minimal. Something like a Valium in an elderly individual, the lasting effects could be greater than 100 hours. Antidepressants are our last class on this particular slide, and I want to focus on tricyclics. Tricyclics are very significant in their anticholinergic properties or drying properties. Anticholinergic side effects are very significant in our frail and elderly, increasing the risk of confusion and potential and ultimately falls. So if you have an individual that's on a tricyclic, we certainly want to reconsider that if they need an antidepressant, using something of the newer classes, the SSRIs, the SNRIs, etc. I'm going to continue my list of classes of medications, high-risk medications. Anticoagulants are very significant risk for our hospice population. I want to share with you that I was able to obtain this summary of guidelines for thromboprophylaxis in palliative care, published by the National Institute of Health in 2020. And I'm going to extrapolate this information from palliative care to hospice care. But basically, they are looking from different medical organizations, and they approach 6 different medical associations to include the American College of Chest Physicians, National Comprehensive Cancer Network, and a few others. One organization, the National Institute for Health and Clinical Excellence, otherwise known as NICE, did provide some information to support their guidelines that thromboprophylaxis should be considered for patients receiving palliative care. However, their thrombotic risk factors should be evaluated versus the significant risk of bleeds and their prognosis. They also state that thromboprophylaxis is not appropriate with the last days of life. So I also want to share that there are some tools available online that you can evaluate patients' risk factors for significant bleeds, and these should be utilized. recognizing that there are indications for anticoagulants, but the risks can be much greater than the benefits, particularly in the hospice arena. As we talk about bleed risks, antiplatelet therapies, and to skip down the NSAID regimens that our patient population use increase the risk of bleeds. Double antiplatelets we often see in aspirin and a Plavix, for example. Know that a Plavix actually provides no added benefit for atherosclerotic vascular disease compared to a 325 milligram tablet of aspirin at end of life. Those medications that we use for diabetes or the anti-hyperglycemic agents, recognize that greater than 30% of our hospice population with diabetes struggles from hypoglycemia, and they have the inability to actually speak to their concerns or their symptoms that they're suffering from. So looking at a particular patient, recognizing that they are taking in less orals than they had been prior, evaluating any insulin regimens and or even oral regimens that are going to affect their blood sugars so that we're not inducing that hypoglycemic state. Narcan is very significant when used with our patient population. It can pose a very significant risk of pain crisis. The Beers criteria, highly recognized and highly adhered to in the long-term care facilities. A few more to mention, we have Fleet's enemas. Fleet's enemas can cause significant acute kidney dysfunction, particularly when combined with anything that has an effect on the kidneys or an effect on hydration status. A couple of examples would be ACE inhibitors, NSAIDs, and aspirin. Benadryl, I believe I spoke to anticholinergic effects. Diphenhydramine or Benadryl has significant drying properties and should not be used in our elderly population. We have the classes of medications that we use for our dementia patients, the NMDA receptor antagonists and the acetylcholinesterase inhibitors. These medications should have ongoing monitoring when prescribed. Our patients that have FAST scores in the 6s should be evaluated regularly for benefit of these particular medications. If they have a FAST score in the 7s, they're not providing any palliative benefits and really should be considered for deprescribing. Note that some medications will state within the literature that with disease progression and unacceptable toxicities that these particular medications should be discontinued. So to provide a quick follow-up for our little old lady in her medications, her lengthy list of medications that she was receiving, our first goal is to improve her quality of life. We want to reduce the pill burden. We want to minimize any adverse effects and drug-drug interactions. So if we look back at some of the medications that she was receiving, particularly the new Dexta, there really wasn't an indication as to why she was receiving it. We know that this is used for pseudobulbar like symptoms. There's also limited literature to support the efficacy of this particular drug. It is rather expensive. It tends not to be on hospice formularies and should be potentially deprescribed. Our little lady has a PPS of 20 and a FAST of 7E, and she's on Nemzaric, the combination donepezil and memantine. I will tell you that this combination product is newer relative to the individual components. It is very expensive. And our little lady prognosis is rather poor with a FAST of 70 and a PPS of 20. So this should be considered for deprescribing. It is documented that she's taking in less than 20% oral intake, and she's been taking Remeron to stimulate her appetite. So I believe at this point, this medication is no longer beneficial and should be recommended for deprescribing. We've got the amlodipine that she's been receiving, but her current blood pressure is hovering around 98/56. We should really consider the dose that she's getting, the frequency, and the potential for discontinuation. NPH insulin, which is an intermediate acting insulin, it can last up to 24 hours in an individual. She's taking less than 20% of her normal oral intake, and this NPH is putting her at significant risk of a hypoglycemic state and symptoms. Linzess is used for, indicated for opioid-induced constipation. It is not on any hospice formulary that I'm familiar with. It tends to be very expensive, and it is documented that our little lady has active bowel sounds. So with our next bowel movement post-admission to hospice, we should really get her started on a standard bowel regimen and discontinue the Linzess. Lastly, the MVI and the supplements provide no palliative benefit and really should be considered for discontinuation. With this, we have recommended deprescribing or discontinuing about 8 or so more medications. Know that this, again, is very simplistic, that it is a stepwise approach, that we should really consider, making 1 or 2 changes at any given time and monitoring. At this point, I will roll over to my colleague, David Bougher, to wrap it up. Thank you.
Thanks, Deanna. Really appreciate the information. I'm hoping when I talk about discussion strategy that for most of you, this is really remedial. All of our colleagues should have some understanding of the benefits and harms of medications, how they change over time, and what to do about it. And this is, I think, sometimes where we get caught up in a little bit of territoriality. So we need to be on the same page. We need to take the lead in making sure that everyone who's involved in this patient's care is on the same page so that we can have productive conversations with the patient and family as we make decisions, help them make decisions about continuing, discontinuing, or decreasing medications that they're on. Again, keeping in mind that doing things like this are geared specifically to be more efficient and effective in symptom management and, again, bottom line, enhance quality of care. So when we talk about how we approach the patient and family, we have to be very well prepared. And I think it requires a stepwise approach. So the first step would be to engage the patient and family and gather relevant information. Things such as, how does the patient perceive the medication or medications that they're on? What do they mean to them? What kind of things have they benefited from? And what kind of things haven't they? So we need to understand the dose and frequency of each medication. And I'll throw in here the piece that Deanna did, their compliance with that. And I don't mean that in a pejorative manner. I mean, are they taking it as prescribed daily or whatever that regimen is? And if not, we know that they're probably not getting the benefits from it, or they're experiencing side effects. So the duration, the indication, why is the drug being used? What's their experience with each of these? Are they effective? Are they difficult to take? Do they cause any adverse effects? What do we want to do about it? sometimes patients are looking for permission to discontinue a medication because, especially in this country, deprescribing is not usually thought of, certainly at the beginning of prescribing a medication. And as you've heard us discuss throughout, many times these medications aren't revisited. I think the next step is to identify and decide which drugs to deprescribe. In Deanna's example, she only gave a few of the drugs that we would consider for deprescribing. There were certainly many more. Just think simply of the fentanyl patch on someone under 110 pounds. And transdermal fentanyl may be another one that we either discontinue and keep it that way or add something that could be more effective. In the third phase, or the third step, we would want to plan, implement, monitor, and follow up. So again, exactly what we would do in the patient's plan of care. What are we going to do about it? So we need to come to this conversation well prepared and understand this is probably not going to be a once only conversation. This is probably going to be a few conversations, if not several, as we go through. We need to be very aware of listening to what we're being told, not anticipate, but listen to what we're being told. Understand how they perceive what's going on and acknowledge their concerns and fears about decreasing or stopping these medications, because if they've been on them for a while, they've been told that many times you can't stop these or you can't decrease these because symptoms will come back. They need to know that we're aware of that and we're going to follow them very, very closely and assure them that we'll do this collaboratively. Deprescribing is not a be-all and end-all. If symptoms come back that a medication was managing prior, we can restart it or go back to a dose that was effective. And we need to have a plan in place. I think when I talk to colleagues, the more difficult piece for most of us is to talk to our professional colleagues. That's certainly other nurses, physicians, attending physicians, et cetera. So we want to make sure that we approach our colleagues very much like we're going to approach our patients. We need to be well prepared. We need to listen. We need to make sure we've done the research. I always do my best, and I'm not always successful, but I always do my best to make sure that I'm over prepared so that I can answer any question that came up. You and I both want to be confident when we approach our colleagues, not arrogant, not defensive, but very confident, because we do come with a level of expertise if we've done this for a while and certainly done the research and understand what we're talking about. Remember, people's time is precious, so we want to be concise in our approach. We don't want a real long story about this. We want to hit the highlights. And don't be discouraged if you meet resistance. Sometimes that's going to be the case. In some cases, it's going to be the professional we're talking to needs time to look at the information, needs a little bit more information. Or there may not be wanting to listen to you at this point. So be prepared to come back, revisit this. Don't take that as a door slammed in your face and you can't go back to it. You can always go back. If asked, you want to offer peer-reviewed research. I don't just normally hand that stuff out without being asked for it. I usually, if something's asked for, well, where did you see this? What's the research show? I'm always happy to provide that through email or, if need be, a printed copy. Keep in mind, you might need to reapproach this at a later time. As I said, meeting resistance initially doesn't mean it can't be revisited. And I think if we keep in mind that this is always about what is best for the patient, I firmly believe we'll do what the right thing will be. So thank you, everybody. We appreciate the time you've spent with us. And I'm going to turn this back over to Greg.
All right. Hey, really great information. Very important and key in providing hospice care to our patients, and thoroughly appreciate everybody's time and attendance today. We are out of time. We won't be able to handle any Q&As, but we've recorded them, and we will include responses with a copy of the PDF from the presentation today, sent out to everybody that attended. Thanks so much for your time, and have a fabulous day.